People with a severe mental illness are more likely to die early from a physical illness and less likely to be physically well than the rest of the population. Most of them do not receive specialist care from mental health services. Because of this, healthcare professionals in primary care have been tasked to provide annual physical health checks. The purpose of the health check is to improve health and to reduce mortality. For this to be achieved, most people will need follow-up support to change unhealthy behaviour. Practical modifications to the way appointments are organised may also need to be made. This will ensure that they are not disadvantaged in accessing this healthcare. This film has been adapted from training that is endorsed by the Royal College of Nursing. You can download an accompanying handout which has some reflective questions. These are useful for revalidation. This training film covers how a person is affected by severe mental illness, the physical health issues in severe mental illness, making appointments accessible, monitoring physical health in severe mental illness, and the importance of supporting behaviour change.
Severe mental illness, or SMI, refers to conditions where psychosis is present. All patients with psychosis, schizophrenia, or bipolar disorder should be included on the Primary Care Severe Mental Illness Register. 6% of the UK population have experienced at least one indication of psychosis. Around 2% of the UK population have experienced symptoms of bipolar disorder, and just under 1% of the UK population has been affected by schizophrenia during their lifetime. Psychosis and schizophrenia typically occur in young people between the ages of 15 and 30, while bipolar disorder often starts between adolescence and mid-30s. Psychosis is not a condition, but a symptom of mental illness. As the senses are altered, the affected person may not be able to distinguish between reality and their symptoms, and may perceive or interpret things differently from those around them. The two main features of psychosis are hallucinations and delusions. When a person experiences a hallucination, they may see, hear, smell, taste, or feel something that does not exist. Auditory hallucinations are the most common type. The person might hear someone speaking to them or telling them to do certain things. The voice may be angry, neutral, or warm. A delusion is a belief maintained despite being contradicted by reality. There is often an element of paranoia. A person experiencing a persecutory delusion may believe that they are being spied on or forced to do something against their will, or someone is planning to hurt them. In those with a grandiose delusion, the belief may be that they have some sort of power or authority.
As people who have psychotic episodes are not always aware that their hallucinations or delusions are not real, they may feel frightened or distressed.
Schizophrenia is a psychotic disorder where the person has episodes of positive, negative, and cognitive symptoms. The positive symptoms include hallucinations, delusions, and thought disorders. Thoughts and conversation appear illogical and lacking in sequence. The negative symptoms are an absence of behavior that the person may have had previously. The person may appear emotionally inexpressive and unresponsive, have poverty of speech, lack the desire for company, be unable to show or feel pleasure, and have a lack of will, spontaneity, and initiative. Cognitive symptoms are frequently experienced, and this includes problems with concentration and task planning. Bipolar disorder is characterized by episodes of elated mood known as mania and depression, during which symptoms of psychosis can be experienced. During a phase of mania, the person may feel euphoric and self-important, be full of energy and have new ideas and plans. They may talk quickly and be easily distracted, irritated or agitated. They often do not sleep or eat and may participate in pleasurable behavior with upsetting consequences, such as spending large amounts of money or engaging in risky sexual encounters. During the depression phase, The symptoms can include feeling sad and hopeless, empty or worthless, and guilty or despairing. The person may lack energy, have difficulty concentrating and remembering things, lose interest and enjoyment in everyday activities, and experience self-doubt. Difficulties with sleeping and waking up early, and suicidal thoughts may also be present.
To recap, people with severe mental illness may experience hallucinations, delusions, thought disorder, cognitive symptoms, lack of will, elevated mood, and depression. Most people with a severe mental illness attending a health check will be stable. A person experiencing an acute psychotic episode is unlikely to respond to the invitation. However, if they do, this should be treated as an emergency. The health check should be postponed, and they should be reviewed by the appropriate person in the practice. It is useful to have an agreed written practice protocol which outlines what to do. Studies have found a mortality gap between people with severe mental illness and the general population of up to 25 years. Research has shown that 75% of this excess mortality is likely to be caused by physical illness, such as respiratory disease, diabetes, and cardiovascular disease. Premature mortality in this group can be amplified by economic disadvantage, by unhelpful health behaviours such as smoking, poor diet, lack of exercise, alcohol misuse, and difficulties accessing and adhering to medical treatments. The antipsychotic medication used to treat severe mental illness is also linked with premature mortality, as it contributes to the development of cardiovascular disease, diabetes, and obesity. Additionally, people with severe mental illness are often not given adequate treatment for major medical conditions which may increase this risk. People with severe mental illness who neglect themselves have the highest excess mortality. Yet, when they are a low risk of self-harm or violence, they are often discharged to primary care, where enhancing self-care is unlikely to be considered. The mortality gap between people with severe mental illness and the general population has not improved, despite increased appreciation of the significance of physical comorbidity. In addition to the conditions causing early mortality, there is a high prevalence of other physical disorders, such as sexually transmitted infections, erectile dysfunction, obstetric complications, osteoporosis, and dental problems in people with severe mental illness. People in this group are more likely to have metastases at diagnosis and die prematurely from cancer than the general population, and less likely to receive specialised interventions for cancer. The symptoms of physical conditions are often not considered or are viewed by healthcare professionals as part of the person's mental illness. To recap, people with severe mental illness are more likely than the rest of the population to die early, have more physical health problems, engage in unhealthy lifestyle behaviours, and less likely to be given appropriate support and treatment.
Please stop the film here for discussion and refer to facilitator notes for guidance.
Making appointments accessible. People with severe mental illness need to be valued by healthcare professionals as much as those with physical health problems to close inequalities in mortality, morbidity, or delivery of care. In order to achieve this, the government placed a legal responsibility on health services to make practical modifications to ensure that people with severe mental illness are not disadvantaged compared with the general population in accessing healthcare. the Equality Act 2010. One way of realising equality in primary care is to make appointments more accessible for this group by adapting the way they are invited and considering the setup of the appointment. Inviting people with severe mental illness for a health check. The capacity of people with severe mental illness to remember the appointment or keep to time may be affected by the symptoms of their mental illness, or they may feel too anxious to attend. They may choose not to go to their health check as they are not always made aware of their risk of increased cardiovascular risk and other physical conditions. This is no different to people without a mental illness who are often not motivated to attend for a checkup when they are uninformed of their health risks. People can be invited by letter and/or telephone or by a prompt from a third party. Several studies in England have shown poor uptake for health checks following a standard invitation letter. Letters offering people an appointment with a specific date and time for a health check significantly increases attendance compared to letters containing an open invitation. Providing a predetermined date and time removes a complicated step in the process for the person with severe mental illness. Increased attendance has been reported in the general population following a prompt letter being sent a few days before the appointment. The letter consisted of a short paragraph which takes about 30 seconds to read, explains the programme of care and provides gentle encouragement.
Hello, Mr. Roberts. It's the surgery here. I'm just ringing to remind you of your annual health check on Tuesday at 10 o'clock. Is that still okay for you?
Studies regarding NHS health checks showed that more people attended an appointment when invited by telephone compared to those who received a letter, and text message reminders had a big influence on participation. There has only been one study regarding telephone prompting specific to people with severe mental illness, and this observed no clear difference in attendance between those prompted by telephone 1 or 2 days before appointment and those who were not. If the person with severe mental illness is in regular contact with their community mental health team, then it could be a good idea to advise this team about their health check appointment. The community mental health team may be able to encourage the patient to come, and in some circumstances might attend the appointment too. National guidance for schizophrenia and bipolar disorder asserts that it is the responsibility of the mental health team to ensure that people under their care receive physical health care from primary care.
Please stop the film here for discussion and refer to facilitator notes for guidance.
Practice nurses and other primary care staff have made some practical changes in an attempt to make it easier for people with severe mental illness to attend their health check, though there is currently no available evidence to support what has been done. The changes include the time and duration of appointment and having a quiet area for waiting. People with severe mental illness may find it difficult to get up due to their symptoms and medication side effects, so avoiding early morning appointments is helpful. People with severe mental illness may struggle with prolonged appointments which offer too much information, although there is a risk of them not coming back if not all actions are completed. Some tips that could help include: make sure the information provided is concise, explain the benefits of returning, and book up any follow-up appointments during the consultation.
Hello, Mr. James. Do you want to come through?
People with severe mental illness may become agitated if they have to wait, and anxiety may be increased if the waiting room is full of people and is very noisy. This can be avoided by having a separate, quiet waiting area or organising appointments at a time of day which is not busy. People with severe mental illness should be treated by healthcare professionals in the same way as any other person being consulted, in that they respond to their individual needs. Some people with severe mental illness can become overwhelmed by their environment, so communicating with them effectively will put them at ease and make good use of the consultation time. Appointments would be more accessible for this group if practice staff can adapt the way invitations are issued and patients are welcomed to the surgery.
Please stop the film here for discussion and refer to facilitator notes for guidance.
It is recommended by the authors of National Institute for Health and Care Excellence Guidance for Psychosis, Schizophrenia and Bipolar Disorder that GPs and other primary healthcare professionals in England monitor the physical health of people with severe mental illness. The physical health check should be carried out annually when responsibility for monitoring is transferred from secondary care. Nurses and other healthcare professionals working in primary care will be familiar with most of the features recommended as part of the annual health check, as they are not dissimilar to those advised for other long-term conditions. It is helpful to use a template of which the content has been agreed by clinicians and managers. We recommend that a health check in primary care should consist of measurements, blood tests, screening, lifestyle, medication review and a care plan. A manual which describes each element in detail is available from this website, which has been designed for primary healthcare professionals carrying out these health checks. The website also houses other useful information and tools. The time available to carry out a health check and the expertise of the healthcare professional carrying it out will affect how much or little can be included. Some of the components may be delivered by other members of the team.
Body mass index and/or waist circumference, blood pressure and pulse should be measured. Electrocardiography, ECG, should be performed on all patients with an increased pulse above 100 beats per minute and on those prescribed high doses of antipsychotic medication. Blood tests. Liver function, lipids, glucose and/or HbA1c should be tested. It is also worth considering whether to test prolactin, urea, electrolytes and calcium, thyroid function, full blood count, B12 and folate, and plasma levels as appropriate, such as lithium. Screening. Discuss dental hygiene and dental visits and recommend regular visits to the opticians. It is useful to examine the person's feet for neglect. Ask if there are problems with urination and inquire about bowel habits. Provide information and instruction about self-examination, testicles, breasts. In women, check cervical cytology has been carried out and ask about their menstrual cycle. Offer advice as appropriate. Lifestyle. As with other physical conditions, advice and support should be offered as appropriate regarding sleep, smoking, exercise, alcohol, diet and fluids, caffeine and drug use, and sex. There are some special considerations to take in people with severe mental illness when supporting them to reduce or stop smoking. Public Health England advise that more research is needed on vaping among people with mental health conditions and its efficacy and safety for quitting smoking. Smoking increases the metabolism of some medications, including antidepressants, antipsychotics, benzodiazepines, and opiates. The doses of these medications need to be reviewed when smoking is reduced to prevent toxicity with further dose reductions as required with continued cessation. Monitor for smoking resumption, as original doses of medication need to be reinstated if smoking is restarted. For those taking bupropion and varenicline, there should be a clearly negotiated plan of support that outlines actions to be taken in the event of change in psychiatric symptoms, especially in the first 2 to 3 weeks. Monitor the mental state of people following reduction and/or cessation of smoking. People with severe mental illness should have a plan in their records which identifies their individual signs and symptoms of a possible relapse and describes the action to be taken by themselves, their family, and healthcare professionals. Each person will display different warning signs, but the most common to look out for are mood changes, loss of humour, irritability and/or agitation, losing concentration, not joining in, talking or acting inappropriately, describing strange plans or ideas, neglect of personal care, dressed in unusual clothes or unusual combinations of clothes, different from their usual attire, appear more sleepy or lively than usual, noticeable weight loss or gain, appearing suspicious or hostile, intolerant of noise, appearing distracted, looking around, maybe hearing voices or seeing things. If a person with severe mental illness appears to be relapsing, they should be encouraged to access help. If they are very unwell, they may not recognise that they need help, so the healthcare professional should contact the person's community mental health worker or GP as appropriate. Medication review. All prescribed medication should be reviewed in the usual manner. Most people with schizophrenia will be treated with antipsychotic medication, which can be divided into 2 types: typical, older, and atypical, newer. Typical antipsychotics include chlorpromazine, flupentazole, haloperidol, perfenazine, pimozide, prochlorperazine, promazine, sulpiride, trifluperazine, and zeuclopentazole. Atypical antipsychotics include amisulpride, aripiprazole, clozapine, olanzapine, paliperidone, quetiapine, and risperidone. Treating bipolar disorder is dependent on how the condition affects the individual patients. Different medication is used in each phase. The acute manic phase: antipsychotics, olanzapine, quetiapine, risperidone, and aripiprazole, valproate, lithium, or carbamazepine, PRN, benzodiazepine. Depressive phase: selective serotonin reuptake inhibitors, SSRI, e.g. citalopram, fluoxetine. Antipsychotics: valproate, lithium, or lamotrigine. Promoting concordance. As with any long-term condition requiring medication, patients are often reluctant to continue taking their treatment for a variety of reasons. Use these points when undertaking a medication review. Provide information regarding their condition. Advise how important it is to take their medication as prescribed and not to miss doses. Ask patients about the type, severity, and duration of side effects. A tool can be used, such as the Glasgow Antipsychotics Side Effects Scale, often referred to as GAS. It can identify what specific problems the person is suffering from. Explore resistance to therapy. Anticipate that the person may be misinformed about the illness or the treatment. Educate to continue taking medications when they are feeling better and describe why maintenance treatment is important. Refer to GP or original prescriber as appropriate if people have side effects or are unhappy about their medication.
Please stop the film here for discussion and refer to facilitator notes for guidance.
Long-acting antipsychotic injections. Antipsychotics can be administered either orally or as an injection. There are many reasons why injections may be prescribed instead of tablets. It is easier for some patients to have one injection fortnightly or monthly rather than remembering to take tablets every day. The exact amount of medication that the patient is prescribed will be taken. When a patient has malabsorption, an injection may be more effective. There is a steady therapeutic medication level from regular injections. There is protection from relapse beyond the time of the last injection. Monitoring lithium. To avoid harm to the recipient, the dosage of lithium needs to be adjusted based on the recommended regular blood tests, usually every 3 months. The blood level of lithium is dependent on renal function, and lithium has the potential to interfere with both renal and thyroid functions. Additionally, clinically significant alterations in lithium blood level occurs with commonly prescribed and over-the-counter medicines. People with severe mental illness taking lithium should be made aware of the known side effects and symptoms of toxicity. Blood tests for urea and electrolytes including calcium, estimated glomerular filtration rate, and thyroid function should be taken every 6 months. And often, if there is evidence of impaired renal or thyroid function, raised calcium levels, or an increase in mood symptoms that might be related to the impaired thyroid function, the person should be monitored at every appointment for symptoms of neurotoxicity, including paresthesia, ataxia, tremor, and cognitive impairment, which can occur at therapeutic levels of lithium. As most patients who have a mental illness are only seen in a primary care setting, it is important that the primary care team takes responsibility for discussing and documenting a plan of care to prevent relapse. This should include current health status, social care needs including how needs are to be met, social support, for example, help from friends or family or voluntary organisations, summary of services received from secondary care, occupational status, early warning signs that may indicate a possible relapse, the patient's preferred course of action, discussed when well, in the event of clinical relapse, including who to contact and wishes around medication.
Flu vaccination. As people with SMI have an increased possibility of cardiovascular disease, consider a flu vaccination. To recap, a physical health check should include measurements, blood pressure, body mass index, and consider ECG. Blood tests, liver function, lipids, glucose, and/or HbA1c, others as appropriate. Screening as appropriate. Inquiry into lifestyle behaviour. Review of all medication. Discussion of the care plan. Consideration of a flu vaccination.
Supporting behaviour change. Physical health checks do not improve the health of people with severe mental illness if the person is not offered any follow-up. For morbidity and mortality to be reduced, any identified unhealthy behaviour needs to be modified. There is evidence to suggest that people with severe mental illness can work with healthcare professionals to learn how to make lifestyle adjustments. Recently, a randomized controlled trial of primary care nurses and healthcare assistants supporting people with severe mental illness to change their behaviour found appointments were well attended and there were fewer inpatient admissions. Structured group education alone is not clinically effective in this group, so people referred to groups such as weight management may require additional support to ensure attendance and engagement. To recap, for morbidity and mortality to be reduced, the person with severe mental illness needs to be offered support to modify any identified unhealthy behaviour.
This training highlights the important role of primary care professionals, whether general practitioners, practice nurses, healthcare assistants or reception staff, in supporting patients living with serious mental health illness. People living with serious mental illness are at significant risk of premature mortality and have a much poorer quality of life. However, as we have learnt, many premature deaths can be avoided with timely identification and treatment of long-term conditions, such as heart disease, diabetes and hypertension. Nationally, it is recognised that this shocking mortality risk must be addressed as a key priority. As such, it is specified as a core commitment in the NHS long-term plan. Healthcare professionals should be mindful of treating the whole person and carry out both physical health checks for people with severe mental illness as well as their mental health checks. There are several barriers that can make it difficult for people with serious mental illness to attend practices for health checks. This can include anxiety and fear. With this in mind, primary care should consider practical changes and reasonable adjustments when arranging appointments to make access much easier and less threatening. Physical health checks are not only an opportunity to identify and treat early disease, but also to promote healthy lifestyles, awareness and improve self-care. This will reduce the early mortality rate in this very vulnerable group and consequently reduce the current health inequalities. Ultimately, our aim is that with the right support, people living with serious mental illness can live happier and longer lives.